Welcome back to the show. Well, we're talking health now. We did tell you that the hemorrhagic fever, Lassa fever, and there's meningitis on the other hand. Now, they are wreaking havoc, but we have to stay ahead of them. And this morning, we're speaking with the leading primary healthcare agency in Nigeria. Well, also concerns diseases and the rest. We're joined by the DG of the Nigeria Center for Disease Control, Dr. Ifedayo Adetifa. He joins us via Zoom from the nation's capital, Abuja. Well, good morning, Dr. Adetifa. It's good to have you on the show.
Good morning. Thanks for having me.
Well, Happy New Year to you, I must say, because it's the first time we're having this conversation. But clearly, your work continues round the clock. I imagine that health issues don't go on holiday, so you have to work round the clock as well. Before we get into some of this hemorrhagic fever, meningitis, and the rest, I'd like you to give us a broad view of the year 2024. Just let's set the tone. So please tell us, what are the major public health issues that we're likely to face this year? I know that a lot of people have hoped to hear this in 2020 when we had COVID, maybe some sort of heads up. But when you look at what the year holds, what are the major public health issues that you think we might have to combat this year, such that Nigerians are aware and ready, being the leading public health institution?
Thank you for that question, and Happy New Year to you. There are a few things to consider. We have our seasonal diseases that we know of, so I think it's relatively easy to set the expectation for Lassa fever, which was already alluded to. We're in the Lassa fever season at the moment. It's meningitis season as well. We had a large number of cases of diphtheria last year. Although the numbers have gone down now, we still expect that we will have the continued challenge of outbreaks of vaccine-preventable diseases as long as vaccination coverage remains suboptimal. And then we have the expectation of the risk of sort of reimagining or emerging diseases. So we have seen dengue in Sokoto and other places, and with what is expected with climate change and human activity in the environment and changes in the behavior of vectors like mosquitoes, we anticipate that we will see a lot more of that. Cholera is a problem that we see from time to time, both seasonal and otherwise, and we expect that as long as the risk factors in terms of water, sanitation, and hygiene persists, we should still expect to see outbreaks of that disease in particular as well. All of the other conditions that may occur in other parts of the continent, Marburg, Ebola, are all risks. Although distant, we know that in this global interconnected village that we live in, any disease outbreak is really just one flight away from your capital, depending on where it first occurs. Back to you.
Dr. Adetifa, in that progress report that you gave about Lassa fever in the year 2018, it's quite concerning. The country recorded over 200 deaths, and this is for a disease that is preventable. What are the things that you're learning from the local governments that have been identified where the disease has been discovered and, perhaps spread and deaths recorded? What are the things that we're learning from these local governments that can help us to better adjust in terms of public health and then prevent the spread in other areas, particularly as we look into 2024?
Lassa fever is what we call a zoonotic illness. So it affects a number of rats or rodents. Doesn't cause severe disease in them, but then when human beings are exposed to saliva, feces, or urine of these rodents, or when they come into our households and contaminate our food, then we get infected. So we know that we need substantial changes in behavior in terms of how we handle food, in terms of how we store food in the within our households, and then even things like the traditional practice of burning bushes and all of that, which sort of destroy the habitat of these rodents and force them to come into our dwellings to look for food. But as with everything else that involves change of behavior, of human behavior, this is a marathon and rather not a sprint, because it is just difficult. I mean, if you think about ourselves, even those of us speaking, even with the right knowledge, we don't always behave appropriately. And one classical example is we all know that we should exercise and we should watch our weight, but that doesn't really, we don't really behave in the way that we should do in that context. So we know that there's substantial amounts of work that needs to be done to continue to encourage change of behavior. We also know at the moment that we need to do a lot more work to actually understand the behavior of this vector, because we are, Lassa fever historically used to happen in 3 or 4 high burden states, but is actually now a national problem. So we are learning and we are planning to implement in the coming year better One Health surveillance, which means not just looking at the human end of things, but also working with academia and other partners to understand what's going on in the rodents. We also know that we need a vaccine. Okay, so you said earlier that it's a preventable disease. Yes, largely, but it does not have a vaccine yet. And in recognition of the need for that, the Honorable Coordinating Minister for Health and Social Welfare in September last year inaugurated the National Lassa Fever Task Force that is co-chaired by the DG NAFDAC and myself, basically to bring a national lens and ensure that national priorities and ownership are reflected in the whole process of developing and conducting clinical trials and research for Lassa fever vaccines. Back to you.
Doctor, the very aspect I want us to get into, which is the essence of this conversation in the long run, is how we can equip citizens to help themselves. With the way this situation is, you have illnesses that have similar symptoms, conflicting symptoms. So you may be assuming you have malaria, not knowing you have Lassa fever. We know what happened with Ebola. We know what happened with COVID and all of that. So sometimes, if you're not a professional, or you may not really know exactly which is where I want you to come in helping citizens. I know that you put out publications on your platform to alert the people, educate the community, and engage them. But there's another opportunity for you to also say, okay, if you feel this or feel that, this is what you should do. I want you to explore that line of thoughts.
Okay, good question. So there are many causes of what we call an undifferentiated febrile illness. So it's just a big term saying that one has an acute onset of fever and other related symptoms, which will be typically body pains, headache, poor appetite, nausea, vomiting, and all of that. The sad thing is that in the early phase of any acute febrile illness presentation, none of those symptoms are classical for any particular condition. So it is very essential for fellow citizens, members of the general public, to ensure that they present to a health center to have appropriate testing and evaluation. It's important to have a proper test to rule out malaria, not assume that it's malaria or typhoid, the other things that people typically do. And it's important to also see healthcare workers so that now that they have a heightened sense of what we call clinical suspicion, they can also take samples to investigate you for all of the things that they are thinking about. So whether it's meningitis or it's Lassa fever. And there are opportunities to make diagnosis if samples, if people present early and specimens are taken for testing. And in the case of Lassa fever, and as applies to many illnesses, early presentation, early diagnosis is really the best predictor of a good outcome in terms of treatment, because outcome is also related to starting treatment early, as all of the supportive treatments that are required. So if I summarize, once you have symptoms, please present to a healthcare facility early. ensure that you are appropriately tested for the diseases under suspicion, and make sure you follow the recommendations, prescriptions, or management plan that are offered by your healthcare worker.
And then comes the natural question, the next question, just how equipped are our healthcare centers, primary healthcare systems for these sort of presentation? Because, I mean, not everybody will come to NCDC. Nobody is expected to come to the NCDC in any case. They go to the hospital closest to them. So how equipped are they? What sort of education have the health workers received such that they're able to, okay, differentiate and then call for the test? Because you said ensure that you were tested, but sometimes you cannot force the healthcare worker to, you know, administer a test that they don't want to administer or they're not convinced you need to get. So help us understand what sort of preparation has gone into this in terms of training, equipping them to adequately handle and manage these cases.
Yes, a very good question. Access to care really, and functioning, or access to good quality primary health care, universal health coverage really is the foundation of national health security. And as you know better than me, previous government or current government have continued to work on an agenda to really strengthen primary health care to ensure that this happens. This is ongoing work. There's a significant deficit or gap over the years, and this will not be cannot be addressed overnight. In addition to that, so we are currently working with the National Primary Health Care Agency to implement infection prevention and control for healthcare workers, and part of that training, apart from helping them understand how to prevent or protect themselves and their clients from transmission of illnesses within the healthcare setting, is to also recognize all of these dangerous diseases and what needs to be done to diagnose them. So what we have in place at the moment is advisories have also been issued for healthcare workers. We historically have opportunities to train states and local government public health authorities on it, and there are actually ongoing training on integrated disease surveillance and response, and even provision of the materials that they need as job aids and all of that. There is a process already established where if you need to investigate one of these priority conditions that are, or what our outbreak prone conditions, all the healthcare worker in the primary healthcare center or the general hospital needs to do is really call the local government's disease surveillance and notification officer. They make sure the appropriate specimens are taken and sent to the lab where diagnosis need to be made. Now, the lab may be actually present in that state, or in some instances, that state is mapped to another lab in another state where the test will be done. Or in the sort of worst case scenario, we have in place third-party logistics systems that can transport specimens to the NCDC or nearest lab that is able to offer the test that is required. We continue to work to expand testing capacity. Our aim is to make sure that all of the priority diseases of concern have their labs in each state that are able to make those diagnoses, and to reduce turnaround time and not having to send all specimens to the NCDC in Abuja or Lagos for testing. Back to you.
Yeah, an important question Kadi asked there, particularly because your statement also noted that the outbreak involved the death of frontline healthcare workers. How impacted is the healthcare system in terms of the death of frontline healthcare workers? And to what extent do they have protective equipment while they battle this disease in affected areas? And while you're answering that, sir, I'd also like you to respond to this. Again, you said it's an issue of national concern and that there may be more need to study the vector. But Ghana, neighboring Ghana, declared an end to the Lassa fever outbreak last year, May, and Ghana is just as affected when it comes to the brain drain in the health sector. As a matter of fact, the report says 4,000 nurses left Ghana in 2023 alone. But what can we learn from Ghana in its healthcare system if it's been able to declare an end to the Lassa fever outbreak as far back as May last year?
Let me start with your the last question. Lassa fever is endemic to Nigeria, to Ghana, Sierra Leone, Liberia, and Guinea. Okay, when Ghana declared the outbreak over in May, that was not the end of Lassa fever. We actually also did the same thing. So there's a process of, we have Lassa fever cases throughout the year. You declare an outbreak when the cases reach or cross a certain threshold. And the essence of doing that is that you recognize the need now to bring to bear extra resources and efforts to bring the disease under control, because the numbers have suddenly crossed a threshold where you declare an outbreak. So a formal assessment is done, like we just did, and actually we will soon sort of formally declare that we do have a Lassa fever outbreak. But then we will do another assessment at some point in time in May or June similarly, and then we will declare the outbreak over and sort of scale down the response activities from a response mode to maybe just being alert or maybe just being in watch mode. So I hope that clarifies what has happened in Ghana, and this is a process that actually happens for all disease outbreaks. We will do the same thing for meningitis as well. A lot of these diseases of concern, they happen sporadically or throughout the year. When you have an outbreak is when the numbers that you are seeing cross a preset threshold in terms of how quickly they have accumulated or what the total number is like. So back to the first question. Often the Lassa fever season is heralded, or the sentinel event is that we have a healthcare worker who has caught that and died. Any loss of a healthcare worker is a really sad event. It's sad, obviously. This is an individual, a parent, a spouse, a child, a relative, has colleagues, has friends. So on a personal, community, family level, that's a big loss. In terms of the healthcare sector, you're losing typically our experienced nurses, obstetricians, senior medical, principal medical officers. That's a great loss in the healthcare sector that is already challenged by inadequate numbers of healthcare workers across all cadres, so whether it's pharmacists, nurses, or doctors, or even some of the other junior cadre. And that just contributes to the challenge of being able to provide quality care, or what we call the human resource for health. So part of what we're trying to do to address that is basically scaling up our national infection prevention control efforts and to make sure that that cascades down to the lowest level. As you know, we got impetus in IPC, as we call it, efforts in the context of the COVID pandemic, and a lot of resources went into setting that up. However, COVID was looked after at sort of the highest level of health care, and so this is where most of the progress has been made. But we are now working to play catch up to make sure that this goes all the way down to primary health care, to secondary level health care, and that this, what we call the Orange Network, which is the IPC effort, really has every qualifying health center in the country participating in it. So back to you. Dr.
Efedayo, there's a question I want to find out, maybe some details. I don't know, the 200 people that died last year, from the data you have, I wouldn't know whether there was maybe an analytics to find out their economic strata, because it's almost tempting to feel that there's a connection between poverty and some of these diseases. Maybe you help us establish that as well. And if that is true, what can be done at the community level as well as government? Because if our vulnerables are also prone to some of this epidemic, or as you guys, as the doctors describe it, there has to be something urgently needs to be done to protect these vulnerable people, we don't have certain level of means and all of that. That's why my colleagues were asking about healthcare facility in terms of the primary healthcare center and all of that. So is there a relationship between poverty and some of these widespread diseases?
It's a good question. I think it doesn't even matter whether it's epidemic or an outbreak-related disease. There is a clear relationship between socioeconomic status and health. And very frequently, whether it's for vaccine-preventable diseases like we continue to see with measles, even with the ongoing diphtheria outbreak, these outbreaks, unfortunately, disproportionately affect those at the lowest levels of our socioeconomic classes. So that's a valid point. And there are a number of interventions, both short and long term, that are being brought to bear to try and address this. Obviously, as a country improves in its economy and makes more money, you lift more people out of poverty. As education gets strengthened, people also move out of poverty and the like. And these are sort of long-term things that affect and contribute in various ways to improved human development index, as it's called. From a health perspective, there is a public health intervention that brings about the most benefit in terms of equity across socio-economic classes. And this is vaccination. Vaccines are available for everybody in every part of the healthcare facility. Yes, there can be challenges, especially when there's, in security challenge areas, disruptions happen to essential healthcare services, and you have a problem. But one of the measures that have been put in place, especially for vaccine-preventable diseases, to make sure that everybody has access to vaccines. And this is why the government continues, along with partners, along with the MPHCDA, continues to work hard to try and address the challenge of vaccination coverage. We are dealing with diphtheria, we're dealing with measles, with yellow fever. They all have one thing in common, is that people are not, there's insufficient uptake of vaccines that are readily available. And vaccines bring about equity. They have the same benefits for the rich, for the poor, if you take them. So that's an important thing for the public to take on board. Now, we recognize that not all diseases are vaccine preventable at the moment, which is why we preach, things like environmental hygiene, water, sanitation and hygiene investments, and even personal hygiene with hand washing and cough etiquette. These are all behaviors that everybody can practice, even whilst we recognize that there are more structural things like overcrowding in your households or in the environment where you live that will require a bit more investment. But overcrowding is not unique to any particular country. Even in rich countries, there are places in parts of those countries where you have such living conditions or scenarios replicated. Back to you.
Dr. Adetifa, I just wanted you to clarify the number of deaths from frontline health workers out of the 218 reported in 2023 from Lassa fever. And also, we haven't touched on meningitis. I'd like you to, again, help Nigerians with the knowledge to protect themselves, particularly about how this disease presents itself also in the area of treatment.
Okay, so for the healthcare worker infections in 2023, if my recollection is correct, I think we had about 45 deaths in healthcare workers, which every death is too much. Our aim is to bring down case fatality in Lassa fever within the next 5 years to a single digit. So there's a lot of work to do there. And that is, healthcare worker deaths really can be prevented if people are able at all times to practice appropriate infection prevention control and be equipped to do that. I think part of the challenge is assuming that somebody presented with an acute febrile illness has something less sinister. Our training and standard for practice is to really take precautions with every case that you see, assume that they have the worst, and take the appropriate protective action. So yes, you talked about meningitis. It's meningitis season as well. We have meningitis through the year. We also have a particular zone of Africa extending all the way from the west in Senegal to the Horn of Africa that falls within something we call the meningitis belt. So this part of the continent, which includes significant parts of Nigeria, is called the meningitis belt because it is prone to having outbreaks of meningitis, especially during this time of the year when it is very dry, it is very dusty, it is cold, and there is an increase, as a consequence, there is an increase in respiratory tract infections because all of those conditions earlier described are not very comfortable for our respiratory pathway. Respiratory infections and all of the conditions that I've just described increase the risk of catching meningitis, which is why there is typically this increase in cases during this period of the year. Meningitis is another vaccine-preventable disease. There are vaccines in the routine immunization that are available as part of the routine immunization schedule that protect against, three common causes of meningitis. There has been the meningitis A vaccine that has been given and has demonstrated the power and utility of vaccines, because since that vaccine was introduced, we've basically eliminated meningitis outbreak caused by the particular pathogen that vaccine targets. So vaccines are beneficial, but during this season, we have alerted, and we expect public health authorities to continue to sensitize people and to ensure that there is early presentation to hospital. There's means for diagnosis. Even ahead of the season, we had spent drugs and things that are required to help manage the first few cases to the high body states. And we just appealed to fellow citizens to protect themselves, ensure that children are vaccinated, but also ensure that when they have a fever, neck pain, body aches and co, that they present promptly to the nearest health center. They can call the State of Ministry of Health hotline or can call the NCDC hotline, which is 6232, to ensure that prompt action and response is instituted.
Those are very important information, and these are some of the symptoms, particularly of meningitis. It's important to talk about these things so that we can all safeguard ourselves. But Dr. Adetifa, it's been a pleasure speaking with you. I'm glad that we do not have surprises. We'll call them surprises for 2024. It looks like some of the things we're expecting, we're able to contend with them, and you've said that we shouldn't expect any surprises. Am I wrong?
No, I haven't said that. We may have surprises.
Oh dear.
So,
but not COVID.
We did. So we may have. So remember that when we had COVID, the expectation was that we would have a flu pandemic because the last one was more than a century ago. I think it's important that the lesson to take is that, while we are hustling for survival and doing all that we do, we live in a shared environment with pathogens and other microorganisms that are doing exactly the same thing, hustling for their own survival. And in many of our activities in the environment we share with them, with animals and other things that we do not see, we come in close contact. Our activities in the environment impact on what happens to them, and vice versa. So there is always the risk that many of the pathogens that we are worried about that may cause an outbreak can cross over from animals to humans. And that's why we have to maintain a heightened sense of vigilance and make sure that we're able to detect these priority pathogens, where they are happening,
right,
and should they actually cause an outbreak. But just to leave you with final points is that most of the outbreaks that we have had, including COVID, are zoonotic pathogens. As I said, these are pathogens that primarily affect animals, but are able to cross over what we call the animal-human interface and infect humans. So Lassa fever, Mpox, COVID, flu, Marburg, Ebola, just the count goes on. And the risk of them occurring remains there as long as we share our environment with animals. Okay. And we need just to remain watchful.
Well, Dr. Adetifa, we have to run now, but we'll hold on to that. It's funny when you say everybody's hustling, but you know what they say, no grief for anybody. So you're telling Nigerians not to grieve for the pathogens,
and for those Nigerians who have a love for, buying that bushmeat when you're traveling down from the southwest. Dr. Adetifa, what do you have to say to them?
No, some people even eat, maybe you add to that question, Dr. Adetifa, people whose pseudo staples are also rats.
I would advise them to please change behavior and find substitutes.
Okay, there you go. Dr. Ifedayo Adetifa, DG NCDC, thank you so much for your time. We wish you the very best this year.
Thank you for having me.
Absolutely. So we've talked about your health. It is very, very important. But we're talking about something that the planet, the world has in store for 2024. It's not to scare you, it's to prepare you for what is coming. We'll talk about those issues, how it affects you and I in a moment. It's still the Morning Brief. Stay with us.